Good evening, everyone. Welcome to our roundtable tonight. The Care Plus Maternal and Family Center roundtable is our time to get together and have face-to-face casual conversations surrounding important societal issues and mental health issues in maternal and family health. My name is Ariel Schatz-Wilderman, and I'm a perinatal mental health licensed therapist. I specialize in reproductive mental health and social justice issues. I'm joined today by three expert clinicians in perinatal mood disorders to discuss the effects of stigma, health inequity, and restrictions to reproductive rights on the mental health of individuals, communities, and our society at large. I'd like to take a moment to introduce the three other women joining us tonight. First, we have Marissa Vesio, who's a licensed clinical social worker specializing in perinatal mental health across a robust client population. She has extensive experience in the delivery of evidence-based, culturally informed care and brings an expert perspective to the implications of reproductive restrictions for body autonomy and health at large. Marissa, welcome.
Hi, thanks.
Megan Warschauer is a licensed social worker who, in addition to specializing in couples and perinatal mental health, is an advocate for equitable sex education. Some of her recent publications include topics like the effects of gender discrimination and ableism on mental health. Megan, welcome.
Thank you.
We have Cynthia Gutierrez, who's a licensed clinical social worker. She brings years of expertise in addressing issues of barriers to accessible care, healthcare disparities, and cultural considerations for the Latino community. Welcome, Cynthia.
Hello, everybody. Thank you for being here.
I also thank you, our listeners, for joining us today. Feel free to use the chat feature for any of your questions for the question and answer segment to follow our discussion. As for the format of our discussion, it'll go as me asking each of you questions given your area of expertise and focus, but feel welcome to chime in at any time. It's a free flow. There's so much intersectionality in this area, so we want to make sure that everyone's voice can be heard. So to get started, let's look at some of the basics about perinatal mental health at large. About 50% of people with postpartum depression are never detected. More than 90% of women with postpartum depression don't have access to help. Suicide and overdose combined are the #1 cause of death in the first year postpartum. But let's dive a little deeper into restrictions and bias surrounding abortion. Cynthia, can we start with you?
Yes, of course. So, longitudinal studies on the mental health implications of abortion and abortion restrictions consistently show that women who were denied abortion access also face greater initial levels of anxiety, lower self-esteem, and lower life satisfaction.
Misinformation is often intentionally used to confuse or stigmatize people seeking to terminate a pregnancy or wanting to learn more about abortion in general, and even dissuade people from considering abortion when making plans for their own reproductive health care. One common misconception is that those who have an abortion regret their decision later. Megan, can you talk more about this and other myths surrounding abortion?
So unfortunately, there's a lot of misinformation out there, both intentional and unintentional, that gets spread by various sources, whether it's friends and family, biased media outlets, or even during mandated pre-abortion counseling sessions that some states do require. Imagine your Aunt Carol reads a post on Facebook claiming that abortions cause breast cancer, and she casually mentions it at Thanksgiving dinner. If nobody takes the time to fact check that, that misinformation can easily spread to others, perpetuating a cycle of misunderstanding and confusion. It's a problem that affects how people make informed decisions and contributes to the stigma around reproductive choices. In some states, mandated pre-abortion counseling sessions provide materials that include misinformation about the potential risks to future fertility, which can be very harmful. There are states in which some women are told that because they're having an abortion, they're at an increased risk for depression, suicidal ideation, post-traumatic stress disorder, and more. And there's really no research that indicates that. A common myth about abortion is that it will always result in regret. Over 95% of women surveyed 5 years after having an abortion reported that it was the right decision for them. When regret was reported, it was due to unsafe abortion practices leading to complications like excessive bleeding, pain, and post-abortion infections. And lastly, politicians and anti-abortion advocates often claim that a significant number of abortions occur late in pregnancy, suggesting that people carry pregnancies for 8 or 9 months and then suddenly decide to seek an abortion. In reality, abortions later in pregnancy typically occur because individuals receive new information about their pregnancies, such as the discovery of a serious fetal or maternal health issue, and decide that they're going to take things from there, or because they were unable to access abortion services sooner.
So, what can be done to change the conversation surrounding abortion and to eliminate the stigma and misinformation that we see?
So, according to Reproductive Freedom for All, amplifying accurate information from trusted sources is the best way to stop the spread of these myths that are being reported as fact. It's also important that you do your own research from trusted information sources such as the World Health Organization. I also think that listening to personal stories can be very powerful in understanding that abortion is not a political or moral debate, but in fact a deeply personal decision. A key way to shift the conversation is by making abortion care an integral part of a broader movement for accessible, affordable, and inclusive reproductive health care. When abortion is treated as part of general health care rather than a fringe issue, it really helps to reduce the stigma.
Yes, and the decision to have an abortion is typically motivated by diverse, interrelated circumstances. Politicians and lay people across the ideological spectrum speculate that women who choose abortion for reasons other than rape, incest, and life endangerment do so for convenience. In your experience in working with those who've contemplated or had an abortion or maybe planning to have an abortion, do you find that to be true?
In order to maintain their privacy, to navigate social expectations, and to protect themselves from the stigma that we're talking about, many women choose not to share their abortion experiences, and that's their personal right. A woman who decides to terminate her pregnancy is under no obligation to explain her reasons to anyone. Every decision is deeply personal, and the factors behind those choices can be super complex. For some, it might be due to financial challenges, the timing of the pregnancy, issues within the relationship, or maybe a desire to prioritize the care and well-being of other children. Ultimately, a woman's decision about her reproductive health is hers to make, and it should be met with respect, empathy, and understanding. Nobody should have to justify their choices regarding their own body because reproductive autonomy is a fundamental right.
Yes, thank you so much for sharing that perspective. A woman's right to make autonomous decisions about her own reproductive health. It's central to equality, privacy, and physical integrity. Research also emphasizes the significant impact of a robust social support on reducing postpartum depression and improving mental health of women and mothers and birthing people. Marissa, coming to you now, how can healthcare providers and communities actively promote the establishment of strong support systems throughout the pregnancy journey, the perinatal journey? So from conception all the way through birth to enhance both maternal and fetal well-being.
Thanks, Ariel. Yeah, so support systems play a pivotal role in maternal mental health because they offer emotional, psychological, and physical support to expectant and new mothers. A lot of research highlights how strong networks of family, friends, and healthcare professionals can alleviate stress, build resilience, and empower women during pregnancy and postpartum periods. A supportive environment helps mothers navigate all the demands of pregnancy and parenting while reducing the risk of postpartum depression. The way we can together actively promote these systems is by creating peer support groups and helplines for expectant and new mothers, train healthcare professionals to identify signs of maternal mental health struggles and connect mothers to these resources, and also encourage family involvement in maternal care and educate them about providing effective emotional support.
Thank you. And then related to body autonomy and the critical nature of body autonomy, especially today, decades old, Susan B. Anthony's advocacy for this cause, she stated the sacred right of a woman to her own person. How does that principle relate today in your practice?
So, bodily autonomy, as Susan B. Anthony articulated, is a sacred right that remains relevant in modern struggles against systemic oppression. MSI United States highlights violations of this right globally in the form of arranged marriages, lack of access to reproductive health care, and societal restrictions on women's choices. These issues deny individuals agency over their lives and continue to contribute to cycles of inequity. Addressing these challenges requires a few different things. I think strengthening international frameworks that protect bodily autonomy, such as the CEDAW, supporting grassroots movements, advocating for reproductive rights and gender equality, and then also working to expand access to healthcare services that can empower individuals to make informed choices about their bodies. As Susan B. Anthony's words resonate today, bodily autonomy is fundamental not only for gender equality, but also for upholding the dignity and agency of individuals across all societies.
Thank you for sharing that quote with us. And that being said, in the political sphere, in light of the restrictive policies, such as the overturning of Roe, what measures can advocates, policymakers, and communities, and anyone on this call today take to ensure these rights are protected and respected?
So the right to bodily autonomy, particularly concerning reproductive health, as you said, remains under threat due to the shifting legal landscapes like Roe v. Wade. The Guttmacher Institute highlights that these changes disproportionately affect marginalized groups, including low-income individuals and people of color, exacerbating health disparities. So we have to really safeguard these rights by advocating for comprehensive sexual education that emphasizes consent and bodily autonomy. We need to support legislation that protects these rights, rights such as access to contraception and abortion services, and collaborate with local organizations to provide resources, education, and advocacy in underserved areas. Supporting these rights requires a lot of coalition building among advocacy organizations. A few of them are the Reproductive Health Access Project, the National Abortion Federation. So really building collaboration, public education on bodily autonomy, and mobilizing grassroots movements to safeguard and expand access to reproductive health care.
Thanks for all of this great work that you're doing. Shifting gears a little bit, Cynthia, you've done so much over the past few years with regards to mental health and maternal mental health in the Latino community. In the context of the ongoing wave of abortion bans across the United States, nearly 6.7 million Latinas in the 26 states affected, representing 43% of all Latinas aged 15 through 49, are among the largest groups of women of color impacted by these restrictions. How do these bans uniquely affect Latinas in terms of access to healthcare, economic stability, social well-being, healthcare at large?
So yes, Auriel, many Latinas in the United States face barriers in their attempts to access to reproductive health care. And due to the rise of these restrictions across the country, Latinas face socioeconomic obstacles. Being denied reproductive health care has its consequences because it denies them the opportunity for family planning, impacting not only their life, but also the life of their children and families. For example, in so many cases, a woman that wants to get a degree, but recently have found out that she's pregnant, maybe she's not gonna be able to pursue this degree because she's forced to carry for a child, losing the opportunity for educational for to get the education that she was planning to. A woman who wants to work full time needs to provide maybe childcare and loses the opportunity to pursue her career of choice. And a woman and her partner that perhaps have been saving money for emergency expenses, future for them, for their children, now they have to invest that money in paying for pregnancy expenses and the postpartum care for the mother and the children or the child. In addition, Hispanic women and women in other racial groups face socioeconomic disparities. We already know that they face obstacles when seeking reproductive health and abortion care. But also there are some wages disparities, and I will draw some numbers so all of you can have a better idea. A Latino woman made 52 cents for every dollar earned by a non-Hispanic man. And when we talk about a Latino mother, they made 47 cents for every dollar that is made by a white father. These low wages are already making it very difficult for Latinas to live comfortably. So imagine adding the abortion care expenses. Right now, abortion care goes between $500 and $700. If we add to this cost the loss of wages for the days that women are gonna take out of work, right? Because many of them, they don't have PTOs or paid sick days, right? In addition to all of this is the traveling costs and maybe hotels if they're traveling out of the state, right? Now, regarding access to care, even if they can find abortion care in their states, there are lack of affordable options. About 27 million Latinos in the United States use Medicaid or other federal health insurance programs. These programs have some restrictions and prohibits federal funding to pay for abortion, except in cases of rape, incest, or if the life of the pregnant individual is in danger, right? So now we know that these individuals, right, they have to pay that out of pocket, right? If they don't go, they they haven't experienced any of these rape, incest, or the danger of their life. So when we talk now about undocumented individuals that seek reproductive care, is a different and more challenging scenario for them. Right now, there are about 7 million undocumented Latinos in this country, right? They are facing many challenges while searching for abortion care or other reproductive health services. And many states with restrictive abortion policies are also states with high numbers of undocumented Latino immigrants. So right now we have been seeing on the news over the past weeks that many undocumented immigrants have been targeted, right? Which is making it even worse and more difficult for them. So adding to all of what I just explained, right? They are also being anxious. They have concerns about leaving their houses, going into the community. So imagine if they don't have driver license because many states don't allow them to have driver license. And also the cost, adding the cost, and they traveling to other states when they know already that they are being targeted, right? So it is a very difficult scenario for these individuals right now.
So what about policymakers? What's the role for policymakers in this?
So one, it is important that the Latino Hispanic community are not overlooked when discussing reproductive rights and healthcare, because as of now, 24 states have banned abortion or are likely to do so, and this is including New Jersey. And second, it's important to continue the efforts to block anti-abortion legislations, fast-checking misinformation, and advocating for reproductive care to make sure all individuals are having the right to privacy to make their own reproductive choices.
Thank you. Just to look at some of the stats again, the recent Nielsen report highlighted that United States and Latino audiences are more likely to receive, consume, and share misinformation online compared to the general population. So, could you speak to the factors contributing to this trend within the Latino communities and what can be done to empower these audiences and this population with the tools and knowledge that they uniquely need to navigate this misinformation surrounding voting, health, civic engagement, not just mental health care?
Yes, so since the COVID pandemic, Latinos in general have been utilizing more social media, mobile apps, and other digital platforms to get information about these topics, right? So one of them is abortion. Like it's very easy for them to access their phones, type on Google, search on YouTube, information about abortion, Latinos, consequences, stuff like that, right? So one factor that makes them a target for misinformation or make us a target for misinformation is the language that we speak because it's Spanish. And why is that? Because many of the social media platforms do not perform the same amount of fact checking in languages other than English, right? So in a recent survey, about 76% Latinos have heard that abortion is illegal in the country. And if a person seeks for abortion care, they're going to get arrested, right? So additionally to all of these, they are using WhatsApp, which is an encrypting messaging platform where also they are exchanging this misinformation. In addition to all of these, also, there are some crisis pregnancy centers that are religious affiliated. So there are no medical providers and they are targeting low income individuals with the idea of, hey, like I'm gonna provide you free ultrasounds, free imagings. And what they do is that once the individuals go to these appointments, they try to give them other information, right? Or misinformation. They they talk to them about the risk that they can die if they get an abortion and they can get deported, they can be arrested. So there is a lot of misinformation, not just on the media or the social media platforms, but also in these centers.
Yeah, thank you. I mean, it's really important that we talk about the issues that people face every single day, the people we talk to every day, that we work with every single day. It's really on the ground issues affecting people individually and as a community. With respect to clinicians or providers in general, how can provider education be improved or expanded in a way that it could be more culturally informed?
Well, when we are working with, specifically with the Latino Hispanic community, I can say that it's important to take into consideration the Latino values, the family dynamics, the health beliefs, the communication styles, and other environmental factors such as the support system that they have in this country or the lack of them, right? Providing also and delivering services to our clients in their own language, right? And sometimes, like we have clients, and in my experience, I've been hearing this in my sessions, that clients go to the emergency room, they go to the pediatrician, and when we ask them, hey, how was your appointment? How are you feeling? They don't know what's going on. And why? Because the providers, the doctors and nurses only speak English. When the client asks, hey, can you translate? They're like, oh no, there are no staff that speak Spanish. So giving them the tools and the information about their rights, because they have the right to ask for a translation services when they go to this appointment, because it's important for them to understand what's going on, right? And also, talking about discrimination, many of these individuals are gonna face discrimination at some point, right? When they go to the community to get resources, when they go to social services, to the Social Security Administration, etc., right? So again, giving them the tools, right, to for self-advocacy, to boosting their self-confidence so they can speak up when something happens. And overall, understanding diversity in our own community and culture, because not necessarily because I'm Latina and I'm Hispanic, I have experienced the same experiences that maybe my client that is from Honduras, El Salvador, Guatemala have experienced, and reflecting a little bit on how different our belief and cultural backgrounds can be. Additionally to all of this is the oppression that many, many individuals in their own countries have experienced in their families, or maybe right now at home with their husbands, right? Why? Because machismo is present in many families that are Hispanic or Latino, right? So giving them the tools again for the self-confidence, to boosting their self-esteem, to teach them about the rights and education, a lot of education for us as providers to get the right information so we can pass that right information to them, so we can reduce anxiety and the fears connected with misinformation.
Yeah, thank you for sharing that really in-depth perspective. Megan, I'm going to switch it back to you, carrying over about provider education and also client education. So, in your practice, how has education changed? What does it look like? Is it different since the reversal of Roe?
Well, for providers, now we must be educated on the risks that our clients face, including the potential for criminal or civil penalties in some states. This includes understanding how to protect patient confidentiality, as well as knowing what information is legally required to be shared with authorities if a patient seeks care across state lines or if they're suspected of violating any kind of restrictive laws.
Okay. And so when it comes to your own experience as a clinician and your own clinical education in perinatal mental health, does anything stand out? What stands out most when thinking about your own education with respect to the reproductive rights? Where can we improve on this? How can we better train providers?
Well, fortunately, Care Plus is dedicated to offering specialized training that enhances our work with the perinatal population. These ongoing training opportunities really equipped us with the essential knowledge and tools that we need to serve individuals effectively and compassionately, particularly in this area of reproductive freedom.
Thank you so much. We've covered a lot today. I love how we've been able to take it down to really this is what our clients are actually dealing with. This is actually the conversation surrounding these issues. And I think it's really important that we, even as clinicians, take a step back and focus on just the day to day. This is what the day to day looks like, sounds like. And I really appreciate all of you sharing your passion. I'd like to leave some time for closing statements and questions and answers. So, Marissa, can we start with you?
Chris, I think you need to unmute yourself.
Oh, thanks, Megan. I was just saying, as we conclude, it's clear that maternal mental health and bodily autonomy are deeply intertwined with social, legal, and healthcare systems. And protecting these rights requires a comprehensive approach, one that combines advocacy, education, and access to essential resources. By leveraging global frameworks, supporting local initiatives, and empowering communities, we can create a more equitable and supportive environment for women everywhere. Let today's conversation serve as a catalyst for continued action, collaboration, and commitment to ensuring that every individual has the autonomy and support they deserve. Together, we can drive meaningful change and build a healthier and more just world for all.
Thank you so much, Marissa. Cynthia, what are your final thoughts?
Yes, so something that I want to add is that it's important that we continue fighting and advocating for those that are who are being silent and not afraid of speaking up. I think it's important to be the voice of many of our clients and focusing on the things that we can control, right? As being there for them, providing them the safe space that maybe they don't have at home to share experiences, thoughts, feelings, worries, concerns, right? And providing them the right information, right? In addition to active listening, because that's the only way that we are gonna identify what are their needs and what are maybe the resources, struggles that they have, right? So thank you, thank you.
Thank you, Megan. How about you?
Well, first, I'd like to take a minute just to, Cynthia, you do so much great work. And, with the Mom Helping Moms group that you run and the community that you're creating and the safety and the support. And I think it would be remiss not to mention that, your coworkers see that. We see all that you do. And, I'm always in awe when I hear your updates. It's really amazing. Um,
Thank
but in
you.
closing, at a time when, rights can shift very quickly, it's important that we remain vigilant, informed, and proactive. Supporting reproductive freedom means supporting the right of every individual to make decisions that are best for them, for their lives, their health, their futures. These decisions should be free from stigma, illegal threats, or political interference. At its core, reproductive freedom is about autonomy, dignity, and the respect for the choices we make about our own bodies. Without it, true equality and justice can't be achieved. As we continue to fight, it's so important to remember that freedom is not a privilege and it's a right that we must continue to defend.
Beautiful. Thank you, Megan. And thank you to everyone, each and every one of you, for sharing your expertise, your passion, and what your day-to-day looks like. At this time, if there's nothing else, I'd like to open up for some Q&A. And let's take a bit of time to look in the chat. We've got a lot going on in our chat. So let's see here. Okay. So we have some questions. Um, Scrolling through a lot of questions. So, Marissa, as a clinical supervisor, how did you come to specialize in the education of interns and the next generation of clinical social workers in maternal mental health? How did you get involved in this topic at your level of supervision?
Let me unmute myself. I don't want to talk on mute again. Um, I think just by our conversation today, I think it's hard to ignore the disparity that we're seeing in maternal mental health, and how important it is for everyone to be educated on and to also have access to all the resources and, as Cynthia said, the correct information, so that they can make the best decision for themselves. So it's been, really important for like that next, generation of clinicians, to have training, and to have support so that we in turn can help our clients.
Thank you so much. And we really want to recognize, as we sit here talking about expanding education, that you're doing it, and we're all doing it today by coming together. Thank you. We have a lot of questions coming in. This one takes it a step further in terms of disparities and health equity. Uh, she asks, they ask, how do maternal mental health experiences differ across racial, socioeconomic, or geographic backgrounds?
I guess I can answer that question, right? Just repeat for me, like the question, the whole question. So
Sure. It's with respect to differences based on racial, socioeconomic, or just where you live, geographical backgrounds. How do these experiences differ based on your practice?
yes, yes, yes. So based on my experience with working with clients that are from different cultural backgrounds, different countries, and different religious beliefs, um, so mental health itself is experienced different. Many clients, perhaps it's because they're not familiar with the symptoms, and now we know because of this country, because of the education and what we're seeing nowadays, right? Perhaps a person that comes from a country from South America. I'm from Peru, and I can tell you that in Peru, we weren't talking about mental health. If we were talking about maternal mental health, it was, I don't know, it was something strange, right? We knew that maybe moms were experiencing some sadness, but it wasn't recognized as postpartum depression, postpartum anxiety, right, or any other mood disorder. So yes, it is experienced different just because it's not we are not getting the right information back in our countries, right? Right now, we are seeing that because of social media, we are getting to know more about what happens during the postpartum, for example, right? During the postpartum phase, now we can recognize symptoms of postpartum depression, something that we didn't have back then. Also, there is a lot of taboo regarding mental health. Many clients, right, they have to experience a lot of postpartum depression symptoms in order to maybe the OB-GYN to recognize, hey, like maybe you need to get connected with a therapist, or even for medication management, because there is a taboo in seeking support or mental health services. So I don't know if that answered the question, but
Yeah, no, thanks for sharing that from your experience. I mean, and with respect to geography, I find that that's something really overlooked. Just being close to a hospital, just having access to, it's not just access to care, it's access to quality care, specialized care. Social determinants of health are huge, and it's something that we in our society and as clinicians every day in every context we really have to take into account. That could be good, bad, or indifferent. What that looks like is how does our access to healthcare, do we live close to a hospital? Stereotypes about certain groups or populations about not being compliant with healthcare. Well, okay, do they live close to the hospital? Are they able to access care geographically, but not just are they able to access it? It's, if I'm in another country and I have a problem and I don't speak the language, it's not accessible care to me because of that gap. It's not just about the socioeconomic factors. There's discrimination and violence, but also education, gaps in employment, gaps in income. Um, one thing that, people will say, oh, you drink some water, stay physically active. We know that that's really kind of key for mental health is physical exercise and basic health and nutrition. But what happens when you don't have safe water to drink? And what happens when your neighborhoods aren't safe to go for a walk? So those are just things that we as a society have to consider to just think about the basic things that many of us take for granted. We have a lot of questions coming in. So I'm going to pull us back to maternal mental health. So, how can partners, family members, and friends recognize when a mother is struggling with her mental health? How do you have that conversation? This is a tough one.
You
Who
know,
wants to take it?
I actually had a client who told me that she was going to write down things for her husband. She said, I really like to knit. I really like to bake. If you see that I'm not knitting and I'm not baking, something's wrong. So maybe
Mm,
kind of having those serious conversations, those, you know, if you look at me and I don't resemble the person that you've known, maybe that's the time that we should have a conversation of like, what, should we talk to someone? What do we do now? Um, and then, within yourself, I think a lot of times you open up Instagram or Facebook and you see a woman with her baby and she's smiling and she's beautiful and you're like, I don't look like that and I don't feel like that. So it's like, is something wrong with me? And I don't want to get help because everyone else is fine with their baby and everyone else is connecting with their baby and can do their hair and put on makeup and, I can't even brush my teeth. So it's like, a lot of women feel, I mean, personally, and that I've learned through, working with moms, new moms, we see this vision of what, you know, we're supposed to look like. And when we don't look like that, we think something's wrong, but instead of getting help, we kind of feel ashamed. Like, why don't I feel like that? So I think it's, having those conversations with partners and friends and family members and just being honest. Like, I don't, I see these pictures and I don't feel like that. And, I was told I was going to have this connection when my baby came. And when I looked at him and looked in his eyes, I was going to feel, this connection. We were going to be bound together, our souls. And you look at this baby and you're terrified. It's like these real honest and like vulnerable conversations and just talking to anyone who will listen to you that cares about you that will put you in the right direction.
Thanks for sharing that also from the couples therapy perspective. Here's a question. Is there any education happening at the high school level among public inner city schools? I can hop in really quickly, just in general in New Jersey. So in general in New Jersey, one answer to that could be that many of the public inner city or underserved high schools are actively engaged in mental health education, including aspects related to maternal mental health. So, the New Jersey Department of Health's adolescent health staff focuses on improving health, promoting healthy youth development, and reducing risky behaviors among teens aged 10 through 19. So, this initiative addresses various health challenges like mental health conditions, and it emphasizes the importance of providing teens with the skills needed to navigate these challenges. So, breaking down each of these programs and initiatives we could have an entirely different roundtable about that. But the importance of policy meets community, which also factors in education and social determinants of health are connected. You can't separate those. So we have to think about does accessible education look like? What does this conversation look like? Yes, we want everyone to have equitable care. Okay, so in order to do that, we have to speak each other's language and we have to meet each other where the patient or the client is.
Well, I think also in terms of sex education, in the high school level, it's focused on abstinence. Don't do it, don't do it. And it's less of like, okay, if you are going to do it, use protection and be safe. And, this is what happens if you're having unprotected sex and you could have a baby. And, I think that there needs to be a bigger focus on, you know, I understand don't do it, right? If you're 14 years old, you're probably not ready to be having sex. But if you are having sex and you get pregnant, I mean, now what? Like, I think kids are having sex earlier and kids are getting pregnant earlier. And I think telling them not to do it, when they tell you don't do it, you just want to do it more because you're like, well, they said don't do it. So it's like providing that education in terms of like what happens when you get pregnant, or like what your options are, or like how things work from there, instead of just making it like a total, like, no, don't do it.
Well, let's take one more question before we wrap it up today. Megan, this is kind of for you. So, in light of the conversations and questions we've just had, with respect to disparities, how can we approach this from an ableism discrimination standpoint? How about the deaf population that I know you've done a tremendous amount of work with? How can you speak to ableism and access
So, when Cynthia was talking
and
about
stigma?
not speaking the language, you go to the doctor and you want information and you can't receive it because your doctor doesn't speak Spanish, right? I mean, this is something that deaf people face all the time when they have, no access to an interpreter, and they go in for services and they don't know, they expect you to read through, pen and paper back and forth, or read lips through a mask. I mean, that's a whole other, I could go on about this forever and ever, but I mean, just culturally appropriate care and using the language and being informed on, what culturally is, right, or like what someone's culture will dictate. I mean, culturally appropriate care is super, super important.
Right. And also, things come up like issues that children face. It's not just about the person who's pregnant. So, children of deaf parents, certainly this has been more in the media. But I mean, really think about it. What is that like? And again, speaking the language, it's also just how we as people relate with each other, and especially in this realm with the stigma about mental health conditions. So how do you just have a communication and empowering providers with the knowledge to know, okay, you don't have to speak to me in this way. I'm not so different there. Okay. Also appreciating that these are the things that I uniquely deal with every day that you may or may not be facing that are really tough. So that's another cultural consideration that I didn't want to look over. Just as I was wrapping things up, we have a lot more
There's a
questions.
there's a great question regarding the barriers that prevent mothers from seeking mental health services, because I know we all hear about them.
Right. Right.
I think a big one is you know, being afraid that your child's going to be taken away.
Right.
Is someone going to say, that lady's crazy, we need to call someone? And, you know, a lot of times it's hard to see that coming and receiving services and talking to someone and working on getting better is important, and it's great, and you're doing the best thing as a mom.
Yes, you are. And one of the questions, just to kind of bring it in to kind of wrap it up to that point, is yes, we talk about moms, we talk about having babies, we talk about postpartum, but we also have to remember that not every pregnancy, and I say this time and time again, not every pregnancy ends with a baby. So that is a whole other thing. Termination, spontaneous abortion. Okay, you can have a miscarriage. Okay, it's an abortion, a spontaneous abortion, right? So again, it's messaging. Not every pregnancy ends up with a baby. It's not someone's fault. These are all topics we talk about a lot, but it also impacts men, partners. So it's not just about women's issues. It's about the whole family and tying it back to where our maternal family center aims to go with that is really honoring the whole family. So that being said, that can look like comprehensive care, not just for the woman or the person who's pregnant, but also we see clients up to 2 years postpartum. And there are even a lot of cultural issues within that we still as clinicians think about, and how can we like better bridge the gap? How can we make this more accessible in every day? Like as clinicians, every moment of every day at some place in our head is this value for people's differences and different cultural backgrounds. Even if we look the same, we can be completely different. And that's something really important that we all take into consideration. No one knows what you mean when you say, you know what I mean? No, I don't know what you mean. So ask. We are all different. Um, so with that said, we have so many questions popping in. I don't want to ignore anybody here. But certainly inclusion in mental health conversations with all family members, going to support groups for fathers or partners, screening's a big thing, screening for paternal depression. That's an area for doctor education. Workplace policies. So paternity leave is one, but again, there's so much stigma and expectation that comes with that. So there are a lot of barriers there.
Well,
Um,
10% of fathers experience postpartum depression. And if the wife, if the woman, the mother has experienced postpartum depression, then it's twice as likely. It's 20%. So for me, if I have a client who wants to involve her partner in a therapy session to kind of talk through some of the things, some of the changes, how can I help? I think it's important that the fathers or the men in the question that was asked are included in these conversations.
Thank you so much. And that being said, regarding access to care, or if you're a provider, or if you're a politician, or if you are here because you just want to be here and we're so happy that you joined us, or if you or someone you know is in need of help, you can contact us at the Maternal Family Center of Care Plus, the direct number to that, and we can put it in a chat. But the direct number is 201-986-5056, or Care Plus admissions 201-986-5000. And it's really important to share that nobody's getting turned down here. It's a really unique center. And I think that based on our clinicians tonight sharing, just those are the issues that are ever present, lets you know how open we are to treating all people from all circumstances and walks of life. If there are any other questions, please come popping them in. I'm sorry we didn't get to everyone tonight, but I really want to thank our listeners, thank everyone. And for more information about perinatal mental health in general and mental health in general, you can visit careplusnj.org. And you're welcome to reach out to any of us as well. So we're all people, we're available. So reach out, ask questions, and we really appreciate your night. So thank you so much for joining us tonight.